moment.
Okay, can you see that?
Yes, I
Okay,
can see your screen.
okay, good.
Thank you, Dr. Daniel. Again, to introduce you, Dr. Daniel to Cornell University, okay, from New York. A great, the best cervical spine surgeon. It's an honor to we hear you again. You can start your presentation, please.
Okay, well, great. Thank you very much. And I'm sorry about what happened. I guess it was last week already. The time zone changed in the United States, and we didn't take into account that. So I'm going to talk this evening about anatomy, radiology, and EMG nerve conduction studies for the cervical spine surgeon. What most surgeons actually don't know. And I've given this lecture to a number of surgeons all over, and find that the vast majority of surgeons don't know very much about EMGs or this type of anatomy. And so I thought it would be hopefully entertaining for you. So these are my disclosures, got nothing to do with anything that I'm talking about today. I do get some royalties on products and bought some stocks in some companies. So I have 15 anatomy and radiology questions, and I have 9 EMG nerve conduction study questions. And so I ask a question, give a bunch of possible answers, and everybody is responsible for scoring their own answers. And so what you should try to do is you should try to answer the questions. The average spine surgeon will, in the anatomy section, only get about 1 to 3 correct. If you get more than that, if you get 4 to 5 correct, you're doing very, very well. And if you get 6, if you get more than a third of the questions right, you're doing really, really, really well. I don't think there'll be anybody that will get more than 6 or 7 questions right. But if somebody gets more than 12 questions right, I would say you really are a genius in the cervical spine. And same thing with the EMG nerve conduction studies. Most surgeons will only get 1 or 2 questions right, but if you can get even a third of the questions, you're doing very well, because unless you're an electromyographer, most surgeons won't know the answers to these questions. But it's important for you to know, because it's actually very practical information that will help you in your practice. So let's, with that, go on and the first question on anatomy: which of these 2 pins, A or B, is in the pars of C2? One of these pins, is it this one that's in pars, or is it this one that is in the pars of C2? And so write down your answers. The second question: with a normal vertebral artery anatomy, which of these 2 screw trajectories is more likely to injure the artery? Is it this screw that goes in like that, or is it this screw that goes in like that? Which one should you be more afraid of injuring the vertebral artery when you put in that kind of a screw? So this type of screw that comes here and goes medially is actually the pedicle screw of C2. This region is called the pedicle of C2. And the starting point of the screw is, if you draw a line on the leading edge of the lamina of C2, and the midpoint of the pars, that would be that spot. You go a little bit lateral to it, and then you can palpate the medial edge of the pedicle with a Penfield 4. Then you parallel that medial edge, and that will be the pedicle screw. Now, before you do that, you got to get a CT scan to make sure that there's no high riding vertebral artery, because sometimes the artery will be right in this area coming from the front, not in this aspect, but on the other side. On the undersurface, the artery will be there, and you'll hit the artery if you haven't seen it on the CT scan. But that is the pedicle, and this is the pars. So a pars screw starts here and goes in that direction. This is the pars screw, this is the pedicle screw. Because the pars screw angles down, it actually parallels the vertebral artery in a direction, and if you angle it too ventrally, it will hit the artery. On the other hand, a pedicle screw starts here and moves away from the vertebral artery. So unless you have an abnormal vertebral artery anatomy that goes high right and goes all the way up here, you will not hit the vertebral artery if it is in a normal position and you start this in the normal area and go medially. So that's the pedicle screw, and this is the pars screw. Question number 3, if a C1 lateral mass screw is too long, what structure is it most likely to injure? So you're putting in a C1 lateral mass screw, it goes too long. Are you going to hit the hypoglossal nerve? Are you going to hit the glossopharyngeal nerve? Are you going to hit the esophagus? Are you going to hit the vertebral artery? Or are you going to hit the internal carotid artery? Now, when they first started using the C1 lateral mass screws, and a lot of people think it was Melcher and Harms that described the C1 lateral mass screw first, but actually Atul Goel from India is the first one to have described the C1 lateral mass screw. People used to say, oh, you can put the C1 lateral mass screw bicortical, you can make it long because there's nothing in front that you have to worry about. Well, that's really not true. There are a lot of structures in the front that you do have to worry about. This is from a paper that Brad Currier out of the Mayo Clinic wrote. He said, the internal carotid artery sits right there. So if you put the screw in too long and out laterally, you can hit the internal carotid artery. Now, it's extremely uncommon for any screw to impinge on a peripheral nerve of any kind because the nerve just gets deflected. The artery is a big structure, it's tethered down. So if you drill, that drilling process could potentially drill right into the artery. So you don't want to put in a screw or a drill that is too long because it can hit the internal carotid artery. The internal carotid artery is lateral, so if you angle medially, you tend not to hit it. But the best way to avoid hitting it is understand where it is when you're looking at the CT scan and avoid hitting it by leaving it as a unicortical screw. Question number 4, what muscle is the most important extensor muscle of the cervical spine? Which muscle is most important for extending your neck? Is it the longissimus cervicis, the semispinalis capitis, the semispinalis cervicis, the splenius capitis, or the splenius cervicis? And why this is important is that if you don't know where this muscle originates out of and where it inserts, and you detach the insertion or the origin of the muscle, you'll end up with iatrogenic cervical kyphosis. So you must know which muscle it is, and that way you know how to avoid it. And the answer is the semispinalis cervicis. It originates out of the transverse processes of T1, 2, 3, 4, 5. So your neck is being pulled on muscles that originates out of the upper thoracic spine, and that it inserts into the spinous processes of C2, 3, 4, and 5. But of these, the most important attachment point is the C2 spinous process. That's why if you do a C2 laminectomy, the patient will almost always fall into kyphosis. And if you detach the transverse processes of T1, 2, 3, 4, 5, let's say you put in transverse process hooks and you dissect it out and you don't reattach the muscles well, that person will develop proximal junctional kyphosis. So you have to understand where these muscles are, and by making sure that the attachments are left alone, you can help avoid a kyphosis. So primary cervical myopathy or dropped head syndrome, one of the causes of dropped head syndrome is primary cervical myopathy. If you take a look at this x-ray, they are lordotic at C2, 3, and 4 and kyphotic in the subaxial spine. That's because the semispinalis cervicis gets very weak. And when it gets really stretched out, because it's still attached to C2, it's still lordosis C2 at the very end of its length tension curve. But because it can't hold the head up, the rest of the cervical spine sags forward and you have kyphosis. Question number 5. What is the main purpose of the C7 and T1 spinous processes? Why is it there? Are the C7 and T1 spinous processes there so that you have a nice looking neck? Well, obviously not. Is it for A, the attachment of the muscles? Is it for biomechanical advantage for neck extension? Or is it C, an unnecessary remnant of when humans became bipeds, saying that if you're a quadruped, you need much bigger C7 and T1 spinous processes, but as a biped, you walk on two legs as opposed to on all fours, maybe you don't need them. So is it the attachment of muscles? Is it biomechanical advantage of neck extension, or an unnecessary remnant? And the answer is this. This is the Golden Gate Bridge in San Francisco that you see here. This is called a suspension bridge, and these are called suspenders. So the way suspenders work is that it offers biomechanical advantage to hold the bridge up. So if you have a low suspender, then it can't hold up the center of the bridge because it doesn't have the biomechanical advantage. The taller this suspender is, the better the biomechanical advantage to hold up the middle of the bridge. And that's exactly the function that the tall spinous processes, the C7 and the T1, et cetera, play. The muscles and the supraspinous ligament, which turns into the nuchal ligament at C7, comes down and pulls on this. So the way it pulls on it is that it is off of the axis of rotation. If this is the axis of rotation, the taller this is, the better the biomechanical advantage. The axis of rotation of the cervical spine is down here, and therefore having it up here allows the muscles to pull on the head and the C2, giving it biomechanical advantage. So it is important for you to be able to pull on it and to extend the neck. Now, what happens if you remove that C7 and T1 spinous process? Well, that's like saying, what do you think would happen to the bridge if I went and just removed one of these suspenders? The cables would be too long and the bridge would sag right into the San Francisco Bay. And that's what happens when you take all of these spinous processes off. That's why you should ideally never do a C7, T1, or a C2 laminectomy. You don't always get kyphosis, but there is a much greater risk of developing kyphosis if you do that, because now all of these muscles and ligaments have been elongated because they're no longer being propped up by the suspenders. Number 6, which of the following is the strongest ligament in the cervical spine? Is it A, the supraspinous ligament? Is it B, the interspinous ligament? Or is it C, the ligamentum flavum? That's an interesting thing. Is it the yellow ligament, the interspinous ligament, or the supraspinous ligament? And I would bet, I don't think I've ever seen a surgeon answer this correctly. So if anybody answers this correctly, pat yourself on the back and let us know, because that means that you know about ligaments. The answer is, it's the ligamentum flavum. And you say, the ligamentum flavum? The ligamentum flavum is like so weak. It's just like a rubber band. It stretches. It's got no viability. Well, that's because this is a trick question. There's no such thing as a supraspinous ligament in the cervical spine, and there's no such thing as an interspinous ligament in the cervical spine. What happens is that from C7 up to the external occipital protuberance, you have the ligamentum nuchae, or the nuchal ligament. The supraspinous ligament is the ligamentous complex that comes from the thoracic spine, and it stops at C7 and then turns into the nuchal ligament as the confluence of all of these ligaments that are just dead center and in the midline. So it's the nuchal ligament that holds your head up, helps hold your head up. Now, you'll see in diagrams and on Google, all these things saying that there's an interspinous ligament in the cervical spine. This clearly was written by somebody who has no knowledge of the anatomy. You might as well say most human beings have 3 eyes. There's an eye right in the top of the nose. The next time somebody dissects out the interspinous ligament and finds a ligament in between the spinous processes, please biopsy it, send it to pathology, have them do a reading. And if it turns out to be an interspinous ligament, please send me a picture, because it doesn't exist. Why is that important for you to know? Now, there is an interspinous ligament in the thoracic or in the lumbar spine, I believe. I haven't been down there in 20 years, so I haven't looked. But I can tell you it does not exist in the cervical spine. And yet people talk about it all the time. I see people at meetings. I see when people doing cervical dissections, oh, I'm preserving the interspinous ligament. And what they do is they cut on one side of the spinous process, they cut on the other side of the spinous process, saying that they are preserving the interspinous ligament, a ligament that doesn't exist. Instead, what exists there is the interspinalis muscle. And this muscle is fed by blood vessels that come from the left and from the right. Now, everybody knows what happens if you cut the blood supply to a muscle on the left side and on the right side. That muscle dies of avascular necrosis. And so if you cut the blood supply on the left and on the right, thinking you're preserving a ligament, it's just going to die. So the way you dissect out the posterior cervical spine is you go in the midline, right through the ligamentum nuchae, divide the interspinalis muscle to the left and to the right, go right down the middle. It's an avascular, amuscular plane. And if you do that, you'll have much less bleeding with your posterior cervical dissections like this. So here's a spinous process, here's a spinous process, and here's a spinous process. There is no ligament there, and there's nothing but air because I've come right down the middle. You see there's no bleeding there because when you come right dead center down the middle, when you're done, there's nothing but air. And this is what it should look like when you're done, because I've divided all the muscles to the left and all the muscles to the right, and I've come right down the middle. And therefore, it should look like this, and there should be very little bleeding in that dissection. So the answer is, it's the ligamentum flavum. It's a weak ligament, but since it's the only ligament of these three that exists in the cervical spine, that is the correct answer. So it's a trick question. Number 7, which nerve is never part of the brachial plexus? Is it C3, C4, T2, or is it all of the above? None of these are part of the brachial plexus, you might say. And the answer is, your C4 nerve actually partially innervates the deltoid in up to 48% of cases if you have a prefix brachial plexus. So Tubbs said that about 28% of us have a prefix brachial plexus where C4 contributes to the deltoid function. So understand that a lot of people have a C4 contribution to the deltoid. Now, why is that important? Let's say you have severe stenosis of C3-4 and severe stenosis of C4-5, and the person comes in and says that they have severe weakness of the deltoid. They can't raise their arm up against gravity. And you get an EMG nerve conduction study, and they say, oh, wow, he's got a C5 palsy. And you look at their MRI, and they've got narrowing at C4-5, and they got narrowing at C4-5 and C3-4. Should you just decompress the C4-5 level? Well, in 28% of Tubbs's cases, that person won't get full recovery of their deltoid function. And in other studies, up to 48% have a C4 contribution. So it could be that their weakness is coming from the C4 nerve root and not the C5 nerve root. So if you have severe stenosis and you have deltoid palsy, decompress the 3-4 and the 4-5 levels to make sure that you cover that 28% of cases where the fourth nerve root contributes to the deltoid function. That's why that's important. Now, how about the other one? Does the T2 ever affect the hand function? Yes. 5% of the cases are post-fixed brachial plexus. So in the literature, it's from 0.4 all the way on up to about 5%. Why is that important? Let's say you're operating at T1, T2, and you've got a huge disc, and you say, I'm going to go around, and the nerve is in the way, so I'm just going to cut the nerve because it's an intercostal nerve. It'll give you some sensation in the costal muscles. So what? If you cut it, in 5% of the people, their hand may become weak because the T2 nerve root is contributing to their function. So you have to understand that that is an important nerve. So the answer to which nerve is never part of the brachial plexus, the answer is C3. I don't know of any articles that say C3 contributes to the brachial plexus. So after a C3-4 ACDF, a patient cannot sing high notes. What is the injury? Is it a vocal cord injury? Is it a recurrent laryngeal nerve injury? Or is it a superior laryngeal nerve injury? And the answer is it's the internal branch of the superior laryngeal nerve. So the internal, it's the external branch. The internal branch of the superior laryngeal nerve is mostly sensory. It gives you sensation to the posterior pharynx. And what it does is it allows you to sense when you're aspirating. So you can paralyze it on one side and the patient may not even know it. But if you paralyze it bilaterally, now they're going to aspirate. Why is that important? When you go in on the right side to do C2-3, let's say, and then next time you need to go to C3-4, you need to have the ear, nose, and throat people do a thorough exam of the superior as well as the recurrent laryngeal nerve. They do video stroboscopy, they do posterior sensation, and by doing that, they can detect if there's a superior laryngeal nerve injury. So it's very important to understand that it's a superior laryngeal nerve. Now, if it's a vocal cord, one side won't move, and so you can easily tell, but that's a recurrent laryngeal nerve problem, not a superior laryngeal nerve problem. And they will, if they can still talk, they can still sing. It's not, the high notes are not affected because it's the external branch of the superior laryngeal nerve that tenses the cricothyroid muscle that allows you to sing those high notes. And if you paralyze that external branch, which is mostly motor to the cricothyroid muscle, that's when you can't sing high notes and scream. Number 9, upon awakening from a posterior foraminotomy. So you do a posterior foraminotomy, patient wakes up and says, I can't talk, I can't talk. What is the injury? Is it an injury to the vocal cord? Is it an injury to the recurrent laryngeal nerve? Is it a superior laryngeal nerve injury? Is it an arytenoid dislocation? Which could it be? And the answer is, it's an arytenoid dislocation. And why is that? Well, let's think about it. You couldn't have done the injury, so it must be anesthesia's fault. Of course, we surgeons always blame anesthesia for everything. So it can't be a vocal cord injury, because if it were a vocal cord injury, yes, the person would have a tough time talking, but to injure the vocal cord, it's very unlikely for the anesthesiologist to injure that vocal cord. The recurrent laryngeal nerve is outside of the trachea in the tracheoesophageal groove. They can't injure it and you can't injure it. The superior laryngeal nerve is outside. They can't injure it and you can't injure it. What you can injure during intubation, traumatic intubation, is arytenoid cartilage. So the arytenoid cartilage is a cartilage that's right next to the vocal cord, and you can displace it. And so you can get it from two ways. As you're intubating, if you do a traumatic intubation, you can put the laryngoscope blade in and lift it up and displace it anteriorly. You can also, if you extubate with the cuff not deflated, you can dislocate it posteriorly, and that deforms the vocal cord. So they're not going to tear the vocal cord. And these days, you're looking at the vocal cord as you put it in. So you're not going to do it blindly and just stick it in and injure the vocal cord. But you can dislocate it, because when you're putting in the laryngoscope, you're lifting it up and you're still visualizing the vocal cord. And as you put the stylet and the tube in and you let go, you no longer are looking, and that's when you dislocate the arytenoid. So if the person has no reason to lose their voice, or immediately upon awakening, the patient can't talk, and you sit there and say, I don't think I injured the recurrent laryngeal nerve. What you want to do is you want to get a CT scan, because on the CT scan, you will see this little thing, that there will be a little bump over here, and you will see this if they look down there. The vocal folds are here and they look perfectly fine. But when you dislocate the arytenoid, it helps to occlude the vocal fold and you'll have difficulty talking. Why is it important to diagnose? Because if you diagnose it that night, the ENT can relocate it. If you don't diagnose it and it scars in like that after a few months, now you got a problem. And now the ENT, I don't know what they do to fix it, but I know that it's a chronic problem that you can't fix by just relocating it. So you have to be really aware to make sure. So anytime you see somebody who wakes up with problems talking, get a CT scan of that area and make sure they don't have an arytenoid dislocation. Question number 10, is this C1 lateral mass screw a well-placed, good screw without any problems, or is it a bad screw? This is one of my cases, and you have to judge, did I do a good job, or did I do a bad job, or you just can't tell based on a plain x-ray? And the answer is, it's a bad screw. Why is that a bad screw? Well, I reported on 2 bad screws at C1, and we did anatomical dissections to figure out why these are bad screws. So this screw is too high. It's violating the occipital C1 joint. Why? Because the C1 lateral mass from the coronal view looks like a bow tie. It's wide laterally and it's skinny medially. Wide laterally, skinny medially. So if you put a screw in over here at this level, it's going to be fine. But if you put that same screw over here, it's going to violate the occipital-cervical joint. So this screw, if it had been a little lateral, would not have violated the joint. But this screw over here would have been way into the joint. And therefore, we have to figure out at what lateral X-ray endpoint will it never hit the occipital-cervical joint. And what we found is if you take the anterior arch of C1 and you divide it into the bottom 40% and the top 60%, if it's between the 20th percent mark and the 40th percent mark, it will never violate the occipital-cervical joint. So if you see this, this is pointed to the top of the anterior arch of C1. That screw, if it is if it's medial, it's going to violate this occipital-cervical joint. Now, if you have an intraoperative CT, you can just check it with a CT scan intraoperatively. But with plain fluoroscopy, it's very hard to tell on an open mouth odontoid whether you're looking at the occipital C1 joint or not. And therefore, look at it on the lateral and make sure that that screw tip winds up between the 20th and the 40th percentile, and then your screw will be perfect every time. So this is the other case. Patient had C12 osteoarthritis, they had cervical kyphosis, they had all kinds of issues. I did an osteotomy, I put in C1 lateral mass screws, and I said, okay, I've done what I need to do, this looks fine. And then post-operatively, when I saw this, I said, I wonder if this is very close, because she complained about headaches on that side. I got the CAT scan, it shows violation of the occipital-cervical joint. So I ended up having to remove that screw. Again, this is up too high. And so it's better to obviously know that in the operating room and take it out than to have to go back at a later date. And that's why we wrote that paper showing where the tip of that screw must be to know that it is a good screw. Next. So is this a good C1 screw? This screw goes all the way here. Let's see, this is the anterior arch of C1. And this is C2 here. So the question is, are these pretty good C2 screws? Now this is a C1 screw. This is a C2 laminar screw. But is this a good C1 screw? And then, are these good C1 screws? So let's take the first one. This is a good screw. This is a good screw. It's in the bottom 20 to 40th percentile, and it's not too long. However, this screw is too long. It looks perfect, but it's actually too long. Here's the anterior arch of C1, and it's at the anterior cortex of the anterior arch of C1. And why is that bad? Because the anterior cortex of the anterior arch of C1 is out here. And if this goes all the way out to there, it is way, way too long. This screw goes all the way out here. This one wasn't mine. But the surgeon who put it in didn't realize that if you go all the way out to there, your screw is way too long. It needs to be about at this level in order to be good. So don't put your C1 screw in too long, and definitely don't put it out here, because you know that now the internal carotid artery is over here. And even if it isn't, there are a lot of soft tissue structures here you got to worry about. Next question. Which are acceptable starting points for a C1 lateral mass screw? Is it A, here, B, here, or C, here? So can you put it in up here? Can you put it in here? Or can you put it down here? Or can you put it in all of those? They all look like good positions for a screw. This is fortunately a very thick posterior arch of C1, so it looks like you can put the screw in anywhere, unless you know that under that lies the artery. So this little piece of bone is called the Ponticulus posticus, a little posterior bridge. And if you put the screw in like here, there's a little piece of the artery that the drill and the screw caught. The artery is lying here. And this is what it looks like. This is the Ponticulus posticus. We reported on its implications for C1 lateral mass screw fixation back in 2005, because we found when I was teaching an anatomy course, people trying to put in the screw there. I said, you can't do that. That's the Ponticulus posticus. That's not a good starting hole for the screw because you're going to injure this. This hole that the Ponticulus posticus makes is called the Rq8 Foramen. And you can see that Rq8 Foramen if you get a lateral C-spine. So if you see a little piece of bone, this is the Ponticulus posticus, this is the Rq8 Foramen, and that's where the vertebral artery lies. So if you see this, and then you see after you dissect a big bridge, do not put the screw here, otherwise you're going to hit the vertebral artery. Number 14, during C1 lateral mass screw placement, there is massive pulsatile bleeding between C1 and C2. So you're working down here, and all of a sudden there's pulsatile bleeding. Is it A, the vertebral artery? Is it B, an engorged venous plexus? C, is it an intersegmental artery? Or D, is it vertebral artery and or the intersegmental artery? Could it be one of those? And the answer is, well, you know, if it's pulsatile, it's not going to be venous, so it's got to be an artery. And as it turns out, this is a case of a vertebral artery that's anomalous. It comes in between, underneath the arch of C1 instead of lying on top of the arch of C1. On this side, the vertebral artery sends an intersegmental artery in between C1 and C2. And there's a little artery on this side. There's a big artery on this side. So this does exist, and other people have described this also. So you can have this vertebral artery in between C1 and C2. Here's another case. The artery comes up here, and instead of lying on top of C1, it lies underneath C1. So if you were trying to put in a lateral mass screw here without seeing this, boom, and you're going to get massive pulsatile bleeding, and the patient's going to thrombose that vertebral artery on that right side. So you have to understand that the artery can be very anomalous. Number 15, the best landmark to determine a thorough decompression during a posterior foraminotomy. Is it A, the lateral border of the pedicle, B, the medial border of the pedicle, C, if you remove 50% of the facet joint, you're done, or D, the ganglion is free? Which one is the best way to know that you've done a thorough posterior foraminotomy? And the answer is, you have to know what the boundaries of the foramen are. So anteriorly, that root is being compressed by disc and uncovertebral spurs. Cranially and caudally are the pedicles. So if this is C5-6, this is C5 pedicle, C6 pedicle. Posteriorly is the superior articular facet of C6 of the caudal vertebra that causes compression. So the root gets compressed between the superior articular facet and the uncinate and any herniated disc material. That's what's causing the squeezing in a foramen. It's the disc osteophyte complex and the superior articular facet. That's what causes compression. And the boundary of the foramen are pedicle above and pedicle below. So if you go out lateral to the pedicle, you're no longer in the foramen. You have unroofed all of the dorsal compression to that nerve root. So the answer is you got to go to the lateral margin of the pedicle. The ganglion, it's hard to tell what the ganglion is and where it starts and where it stops. That's why it's not a good landmark, because it looks all kind of thick in there. So the way you do it is you look at the interlaminar V between. So if you're at C5 and C6, you look at this V, and your pedicle is going to start right about at that interlaminar V. Now this is opened up a lot, but it would be normally here. Your pedicle would start here, and it would take up about 50% of the facet joint. That's why, yes, you do have to remove about 50% of the facet joint, but that's not what tells you. So the first thing you do is, so you say the pedicle is here, I need to remove enough of C5 to unroof C6. you get the C6 unroofed, you cut a trough here and here, you remove that, and then when you're lateral to the pedicle, you know you're done. So here we are removing C5, we've exposed the C6 superior articular facet, then we remove this in an L-shaped trough here. This is removed. Once it has been removed like that, then you make sure that that pedicle is there and you've gone to the lateral margin of the pedicle. So here's the pedicle here. You've gone to the lateral margin of the pedicle, and here's a nerve root. That's the disc space. And since you're lateral to the pedicle, that nerve root is completely free and outside of the foramen. So that's why it takes about 50% to get outside so that you know that the nerve is no longer being impinged. All right, now let's go on to EMG nerve conduction studies. And there are 9 questions to this. The first question is, which of the following can be diagnosed with EMG nerve conduction studies? Is it myelopathy, multiple sclerosis, ALS, all of the above, B and C only, so multiple sclerosis and ALS, A and B only, myelopathy and multiple sclerosis, or A and C, myelopathy and ALS? Which of these can you ask a neurologist to diagnose with EMG nerve conduction studies? The answer is only ALS. ALS initially will look like a radiculopathy. Multiple sclerosis and myelopathy are preganglionic lesions, and the EMG only tests for postganglionic lesions, so we will not see any problems with myelopathy or multiple sclerosis. They will be normal on EMG nerve conduction studies, whereas ALS will look abnormal. If you have ALS that involves only one nerve root, they can't differentiate between that and a radiculopathy. It'll look identical. It's when ALS starts to march on and get nerve roots on the left and on the right and the legs and in the arms that they say, you know what, this is not multi-level radiculopathy, this is ALS. True or false? A patient has foraminal stenosis of C4-5 and C5-6 and has mild weakness of the biceps. So they have a C5, C6 foraminal stenosis, and they've got a weak biceps. And you look at it and you go, I don't know if I should do both the C4-5 and the C5-6 level or just do one of those. Let me get an EMG and ask the neurologist to tell me which of these two is causing more symptoms. Will the EMG in most cases identify which one is symptomatic and tell you you should just do C5 or you should just do the C6 nerve? So can it differentiate between a C5 radiculopathy and a C6 radiculopathy? Is it true or false? Question number 3, a patient has a similar question. Now the question is C8 versus T1. Can the EMG differentiate between the two? So the surgeon orders the EMG nerve conduction study to try to figure out which level to operate on. The EMG will, in most cases, identify the symptomatic level and tell the surgeon, yeah, just do C8 or yeah, just do T1. Is that true or is it false? Can the EMG differentiate between the C5 and C6 nerves or between the C8 and T1 nerves? And the answer is no. Both are false. It's very difficult to differentiate because the tested muscles are very commonly dually innervated by both nerves. And so that's why the electromyographer almost never says you got a C5 problem. They say you have a C5-6 radiculopathy. You have a C8-T1 radiculopathy. And if you ask them, well, which one should I operate on? They say, I don't know. I can only tell you it's the C8-T1 nerves that are affected, and I can't tell you if it's C8 or T1. So look at the MRI and decide which one. So if both are bad, you need to decompress both of them. A radiculopathy causes dense numbness, and there's no weakness. It just causes dense numbness. Which is most likely? Both the EMG and the nerve conduction studies are totally normal. So you send them for a test, they got dense numbness, it's a radiculopathy causing it, and the neurologist says, everything's normal, I don't see any evidence for radiculopathy. Is that A? B, both the EMG and the nerve conduction study are abnormal. The neurologist says, oh boy, your EMG and the nerve conduction study are very abnormal. C, the EMG is normal, nerve conduction study is abnormal. And D, EMG is abnormal and the nerve conduction study is normal. And you would be surprised how much this comes into play, because often you will actually get a condition like this. I just sent an EMG nerve conduction study on a patient that I was sure had a radiculopathy. And they came back and said the EMG and nerve conduction study are both normal. There's no evidence for carpal tunnel syndrome. There's no evidence for cubital tunnel syndrome. There's no peripheral nerve pathology. And there's no evidence for any cervical pathology. And yet the patient has dense numbness, just like this patient. No weakness, but dense numbness. So what I told the patient was this. This is classic for someone who has a cervical radiculopathy. This is what I expect to find in somebody who has no peripheral nerve compression and has a pure cervical radiculopathy causing only numbness. Why? Remember, radiculopathy is a preganglionic lesion. It occurs inside the spinal canal. It does not affect nerve conduction study. So the nerve conduction study in a patient with really bad numbness due to a cervical radiculopathy will be perfectly normal because they're only measuring for carpal tunnel, the conduction velocity here, and the axon transmits that nerve perfectly fine. That's not the problem. So they'll say negative for carpal tunnel, negative for cubital tunnel. But the nerve conduction study can't tell if the sensory nerve is being impinged inside the spinal canal. So they'll say it's normal. On the other hand, EMGs only test for muscle function, so it can't pick up sensory deficits. So the EMG is going to be normal, and the nerve conduction study is going to be normal. So the EMG nerve conduction study will be totally normal if you don't have any muscle pathology, if it's only numbness due to a cervical radiculopathy, and there is no peripheral nerve compression. So if you see somebody with bad numbness and the EMG nerve conduction study is normal, you can say that means that the patient has a cervical radiculopathy. Why is that important? In the United States, we have to get insurance approval. And if somebody's had an EMG nerve conduction study and they only have numbness, I often am talking to a doctor who says, well, the EMG nerve conduction study is normal. And so I don't think they've got radiculopathy. I say, well, let me explain what the EMG nerve conduction study does. And then I have to explain carefully to them. And then they say, oh, okay, I understand now. All right, we'll approve it. Now, can an EMG nerve conduction study identify if a patient has a prefixed or a postfixed brachial plexus? Remember, we talked about it earlier. Prefixed is C4 contributes to the brachial plexus, and postfixed, the T2 contributes to the brachial plexus. So can the EMG nerve conduction study identify if a patient has a prefixed or postfixed brachial plexus? A, yes, in most cases. B, sometimes they can detect. C, absolutely not. There's no way they can ever tell. And the answer is absolutely not. They cannot tell. What they do is when they find an abnormal finding like a deltoid palsy, they say a deltoid means C5. They don't know if it's C5 in that individual. They don't know if it's C4. They don't know if it's C6. All they know is that deltoid equals C5. So when you see an abnormal deltoid on EMG, they say it's a C5 dysfunction. Just like when they see triceps, they say it's a C7 dysfunction. They don't know that the triceps is in fact innervating that muscle or not. So if there's an anomalous distribution, they have no idea. The only way you can tell is by doing an anatomical dissection of the person's brachial plexus. In the best of hands, what percent of true radiculopathy will EMG nerve conduction studies be totally normal? So in other words, a person has radiculopathy. You get an EMG nerve conduction study and it's completely normal. So the electromyographer completely missed it. It's a false negative. They have disease, but they can't pick it up. And the answer is up to 20% of the time, the EMG nerve conduction study will be normal in somebody who has a true radiculopathy. They got atrophy. Now, it's not going to be usually like this, but let's say they have atrophy and profound weakness of a muscle. And the electromyographer, who's very good, says, I can't find anything wrong. That can happen up to 20% of the time. Now, the more severe the disease, the more likely they are to pick it up. But in early radiculopathy, where they have muscle weakness, they may not be able to pick it up. The other thing is, it takes several weeks from the onset of muscle weakness until they can pick it up. So if you see somebody with a C5 palsy, immediately post-op and they can't lift their arm up against gravity, and you send them for an EMG nerve conduction study, they'll say it's normal. Why? Because the neuromuscular junction hasn't had time to disconnect and there's no fibrillation yet. And so they can't pick up. So it takes about 4 weeks for that to happen. So you got to wait to get the EMG nerve conduction study several weeks after you have a motor injury. Number 8, in the best of hands, in what is the false positive rate for EMG for radiculopathy? In other words, the neurologist says the patient has radiculopathy. In what percent are they wrong that there is really no radiculopathy? So they say there's radiculopathy, but in truth, there is no radiculopathy. The answer is only 5%. So if they say there's something wrong, they're right 95% of the time. So if they say there's carpal tunnel syndrome, they're right 95% of the time. If they say there is a cervical radiculopathy, they're only wrong 5% of the time. Final question. This is a patient that I saw a couple of months ago, maybe now about 3 months ago. 45-year-old woman comes into my office. She says she's got neck pain, no arm pain. She has pretty bad weakness in the right upper extremity and the right lower extremity. She has normal sensation. She has hyperreflexia. She's got a positive Hoffman's, positive jaw jerk reflex. What should you do next? Should you get a myelo-CT? Should you get an EMG nerve conduction study? Should you get SACPs? Or should you just take her to surgery for the myelopathy? So on the AP, she has uncinate hypertrophy on the right side. Could be causing weakness. She has anterolisthesis of C3 on 4, collapsed discs with posterior osteophytes at 4.5 and 5.6, cervical stenosis, worst at C5.6 with retrolisthesis, large osteophytes, squeezing of the spinal cord, and you can see indentation of the ventral cord here and flattening of the ventral cord, and foraminal stenosis at both levels. So what should you do? What should you do? Get a myelo-CT, EMG nerve conduction, SSCP, or take the patient to surgery? And I'll tell you what I did. I sent her for an EMG nerve conduction study. And she ended up having ALS. So remember I said earlier, if you have somebody who has ALS, initially it looks just like a radiculopathy. But if you get more and more muscle involvement so that the entire right arm is weak and even the leg is weak, there's no radiculopathy that causes that. And if it's a myelopathy and you look at this and you go, wait, it's the left side that's weak, but it's the right side that's more compressed. And it doesn't look bad enough to cause such bad findings that their legs are off. That just doesn't make sense. So there's got to be something else going on. Either she is faking it or she's got something really bad. And so the EMG nerve conduction study came back. The next day, the neurologist comes into my office and said, you know what, you put in your note, the patient has amyotrophy. We need to rule out all causes of amyotrophy. So we are sending her for an EMG. I don't say ALS, I just say amyotrophy. That means you got muscle weakness without sensory deficits, without any arm pain. And turned out she had ALS. Really bad diagnosis, obviously, but it would have been even worse because the person who saw her before me said that he was going to do a 1-level corpectomy on her. Imagine if you're the surgeon that did a 1-level corpectomy for a patient who has ALS. Not a good thing. So if you see multi-level root involved, multi-level weakness with no numbness and no arm pain, get an EMG nerve conduction study to make sure that they don't have ALS. So in conclusion, with an EMG nerve conduction study, you cannot diagnose myelopathy or multiple sclerosis, but you can diagnose ALS. You can't differentiate 5 versus 6, and you cannot differentiate 8 versus T1 radiculopathy. With nerve conduction studies, it only tests peripheral nerves. So it will be normal in every case of cervical radiculopathy. Nerve conduction study is only there to rule out peripheral nerve compression. It has nothing to do with cervical radiculopathy. The only way you diagnose cervical radiculopathy is if the EMG can pick up a muscle abnormality. And as I said, if you send somebody with a deltoid palsy right after they've had it, EMG will look perfectly normal because the neuromuscular changes have not occurred yet. Next, you cannot detect an anomalous anatomy or anatomical variation. So you don't know what the brachial plexus looks like or which nerves are contributing to the deltoid or the hand function. In the best of hands, the EMG nerve conduction study will have a 20% false negative rate and a 5% false positive rate. And finally, always get an EMG nerve conduction study if a patient has weakness without pain or numbness to rule out ALS. And that way you will never miss. Well, that's not true. You can still miss ALS early on in the disease because it can look like a cervical radiculopathy. Thank you very much for your kind attention and for inviting me today. And I'd be happy to answer any questions if anybody has any. And so did anybody get like more than 50% of either of those questions right? I've yet to meet anybody that has done that unless they're an electromyographer or an anatomist or they spend a lot of time looking at cervical anatomy like I do. All right, I will. So did anybody get like more than 50% of either of those questions right? I've yet to meet anybody that has done that unless they're an electromyographer or an anatomist or they spend a lot of time looking at cervical anatomy like I do.
Thank you, Dan. Fantastic presentation. In many cases, if you relate to the, I saw in my practice. Everybody have any question? Bruno?
I would like to speak something. Can you hear me?
Yes.
Yeah, I was very curious about your team because it's a particular team, but I figured out that the team is very appropriate because I'm sure that most of us don't know about these questions. I was very impressed about the ligaments in the cervical spine. So it was very, very interesting things you showed us. So I would like to congratulate you because I have learned very much in this talk. So is someone in this audience who would like to ask something? Could you ask you straight to Dan?
Yeah, it's interesting that so when I was in fellowship, I was taught to preserve the interspinous ligament. So I was always taught cut on one side and cut on the other side. And for many years I did that and they would always bleed. My posterior cervicals would bleed 150 cc's just during the dissection going from occiput down to the thoracic spine. It would always be bloody. And I would say, why is this bleeding so much? Because ligaments shouldn't bleed. And then I went to the anatomy books and I looked at it and the anatomy book said there's an interspinous ligament there. So I said, well, it's a ligament. I don't get it. And then I started probing it and looking at it under the microscope. And I realized that's not a ligament, that's muscle. And then I looked at other anatomy books that said it's the interspinalis muscle. There is no ligament there. And yet I know many, many people that are under the impression that it's the ligament. One of my fellows was taking the licensing exam and he had a person that was administering the exam. And he said, well, we dissect it this way to move the muscle aside because of course there's no interspinous ligament. And the person who was giving the test goes, what do you mean there's no interspinous ligament? Of course there's an interspinous ligament. And my former fellow said, well, we were taught in fellowship that there is no such thing as interspinous ligament. And we've dissected it, and there's no ligament there. And luckily, the guy who was giving the test was a friend of mine. And he goes, well, you tell Dan that that there's definitely a ligament there. And so the next time I saw him, I said, listen, the next time you're back there, if you find a ligament, biopsy it, stick it in formalin, send it to the lab, have them tell you whether this is a ligament or a muscle. And if they find that it's a ligament, I owe you a drink. And of course, he's never found the ligament because there's no ligament there. It's the muscle. But everybody thinks there's a ligament there. Everybody. I mean, it's my teachers all thought there was a ligament. My partners all thought there was a ligament there. And when you tell people there's no ligament, they go, what do you mean there's no ligament? Look at this anatomy book. It says there's a ligament there, but there isn't. The next time you're doing that dissection, look for yourself and you'll see there is no ligament.
Perfect. Ô Chico, você sempre tem alguma coisa para apresentar aí, quer acrescentar aí, quer dizer alguma coisa da sua experiência? Queria ouvir você aí.
Infelizmente, diante de uma apresentação dessa, tão maravilhosa e tão não usual, muitas coisas que não é usual a apresentação dessa. Então, realmente, por isso que ele disse que são poucas pessoas que iriam acertar as questões, que são questões realmente que fogem de livro, e fogem completo de ensinamento para nós. Realmente é extraordinária, que nem uma última aula que ele deu foi maravilhosa. I'm so grateful of your attention, your lecture, Dr. Dan. It's wonderful presentation, and I'm telling for my friends that not usual presentation. This is completely different from the others, but you're expert that because the last presentations you send me 20 questions. If you are right in 5, you are very nice and very nice presentation that I'm learning in the last presentation of you, and this was wonderful too. Thank you so much.
Perfect. Thank you very much.
Marquinho, você que é o cara aí do esporte, tem alguma pergunta aí, alguma consideração?
Good night. Thank you, Bruno. Dr. Dan, congratulations. Perfect presentation. For me, this is so important. No, I don't have any questions, but just saying that what I was talking in private with a colleague that is also checking this presentation is how much we make mistakes. Né? We made so many mistakes, misunderstandings in the real diagnosis of the patient. So I think this is a perfect presentation for us to pay more attention for the physical exam and have a good neurologist to help us. This is very rare here. Most of the time we don't have enough time. We should have, but we don't have enough time to make the right physical exam, and we don't have these good guys, neurologists, to help us all the time. It's a little difficult here. So this is very important. Thank you. It's a pleasure to see you. Thank you.
Great to see you too. Thanks so much for the kind words. And what are you drinking? You got a lot of good stuff behind you.
Yeah, I have a bar here. Nice. I'm not drinking anything today because I have a surgery tomorrow morning. But tomorrow night I'll choose some of them, probably a beer, and have here. And you are welcome to come when you come to Brazil to come here to.
Very nice. I mean, that looks like a professional bar. You've got lots of great stuff up there.
Perfect.
That's my house.
Yeah, that's very
perfect.
Nice. No, I agree that it's so important. The exam and the diagnosis is just as important. You know, when I train fellows, they think at first the most important thing is to learn how to operate. And it's important. In order to be a good surgeon, you have to have good hands and you have to be able to do the surgery itself. But as I say, the best operation done on the left hand isn't going to help if the problem is the right hand. So if you operate at C5-6 and you should have operated at C6-7, the most technically perfect ACDF at C5-6 isn't going to help if it's C6-7. The best looking screw on a lateral x-ray isn't going to help if it's violating the occipitocervical joint. So that's why you have to understand what x-rays show, and you have to understand what EMG nerve conduction studies can do for you and what EMG nerve conduction studies cannot do for you. And it's very important to see that. And it's not just in Brazil. I can tell you that I see surgeons in New York City who don't know this, and it's not their fault. I mean, we don't get educated on a lot of this kind of stuff in medical school or residency or fellowship, and we expect that the neurologist is going to kind of tell us what's going on. So, you know, I don't look at the EMG squiggles. I just look at the report, and they say there's carpal tunnel or there's no evidence for a. And so often I would get this thing that says no evidence for radiculopathy. I would say, how can there be no evidence? The person has a deltoid palsy, or the person has dense numbness in the hand. How can it be completely normal? So then I started to ask the neurologist, what's going on when you're doing an EMG nerve conduction study? And that's when I learned about all of this stuff. And that's when I educated myself that what the EMG actually tells you, what the nerve conduction study actually tells you. And so we're actually writing a paper about this and asking these questions. And we're going to send out a survey to surgeons all over the world asking these types of questions to see how well they know EMG nerve conduction studies. Because I can tell you, when I ask spine surgeons and I give this lecture at various places, nobody knows. It's normal for surgeons to know nothing about EMG nerve conduction studies.
Last week, I saw a patient with T11-12 hernia with cone compression. And I sent him to the neurologist, and I didn't expect that, but he get the patient examined. So he called me. I examined this patient. Oh, it's the first time I saw this in my life. He didn't just do the electromyography. He examined the patient, and he said to me, this is very severe compression. Okay, thank you. He helped me a lot. I took his phone. This is my friend.
Yeah.
From now on.
No, I mean, it's very important. And a good electromyographer has to also know what they're looking for. And that way they can pay attention to different things and be very good at it. Just like a good surgeon must be very good at taking the history, doing the physical exam, being a great neuroradiologist, and then being technically a great surgeon. So all of those are important to getting a good result as a surgeon. All right.
Oscar, you are here, Oscar?
Okay, I think that's it for the questions and comments. If any other questions or comments I can answer?
No more comments? No more questions?
So next presentation, you perform a piano play for us.
No, that's my wife and my son and my daughter play the piano. So unfortunately, I have no talents when it comes to musical instruments. But looks like you play the guitar there.
Yeah, I made it there up there.
Wow, you got 1, 2. How many guitars do you need?
I have 8 guitars, 8 electric guitars, and 4 acoustic guitars.
Wow.
It's my collection.
Yeah, very nice.
Yeah.
Very nice.
We need this.
Yep. All right, well, great seeing all of you, and have a great evening and a wonderful weekend.
Okay,
Thank
for
you,
you
Dan.
too. Thank you very much for spending your time for us.
My pleasure, and thank you. All right, have a good
Para
night.
todos os colegas, tá? Essa aula vai estar disponível no nosso canal a partir de amanhã. Eu vou passar o link para todos vocês. Aí vocês se inscrevam lá e vão poder ver essa aula, que acho que tem que ser vista com mais detalhe e mais calma, né? Thank you too much, Dan. I see you.
Have a good night. Take care. Bye-bye.
Bye-bye.